Greetings everyone, this is Vigneshwaran. I am here to talk about my work on genomic landscape-based in silico prediction framework for personalized therapeutic regimen in cancer patients, being presented at the 8th Annual International Conference of the BGCI. Let's start with a brief introduction of my work. In the era of technomedicine and artificial intelligence, computational tools have found their application in all domains of our life, including health and medicine. Being cost and time efficient, some of the tools used, especially in oncology, assist us in predicting tumor type, staging, therapy planning, patient care, and even estimate impact of genomic alteration. So our objective here is to build a framework that could filter del disease SNPs with the help of in silico tools, which will be followed by 3D structure modeling and utilizing them for molecular dynamics simulation and docking studies with therapeutic drug to identify potential drug based compatibility on specific alterations. The methodology is summarized in the form of flowchart, starting with selection of genes. So we have considered 736 genes reported by the cancer gene census by Cosmic. Then the canonical transcript of these genes are obtained from NCBI and Ensemble databases. The sequence were then mutated computationally to obtain all possible alterations that can occur in the gene. Then the SNPs are subjected through 25 in silico predictors from three domains, namely structural, functional, and conservational impact predictors. The cumulative prediction helps us converge on to a subset of SNPs which are potentially deleterious. The resultant protein 3D structure is predicted computationally, which we subject through molecular dynamic simulation and docking studies in complex with therapeutic drugs and are compared against their wild-type counterparts. The results of these would help us understand which drug would be a better fit for a particular patient with a unique genomic landscape. We will discuss about the result of one case study obtained from this framework. The variant considered in this test case is A146T variant of the KRAS gene, which has been reported in multiple solid tumors including adenocarcinomas of lung and thyroid. The first line of therapy used in this case include MEK inhibitors like trametinib, cobimetinib, and binimetinib. So we performed docking of these drugs with predicted protein structure of wild type and the variant of KRAS using Autodock 4. We found that binimetinib binds efficiently with the A146T variant, suggesting that it might end up binding with KRAS variant and not perform its primary activity of inhibiting MEK. Thus, it could be suggestive that trametinib and cobimetinib would be a better fit than binimetinib for a patient harboring KRAS A146T variant. I conclude by putting forth the point that the framework would help genetic counselors and clinicians in curating personalized therapeutic regimen for a patient with a specific genomic landscape. I would like to end the presentation by thanking the funding agencies for their support and Dr. Aruna for providing us with essential clinical and genomic information for the case study. Thank you.